All right. Hello, everyone, and welcome. So this is cardio part 3, okay? So we are going to cover blood pressure medications, and practice questions. Okay, that's kind of our plan for this session. So with blood pressure, a couple of extremely important concepts you need to remember and keep in mind. Also, there are some minor things I'm going to mention to you that I don't want you to forget because they're part of those select all that applies, okay? So there are different categories for blood pressure. First of all, somebody's not diagnosed with hypertension with one assessment of their blood pressure being elevated, right? So you know the norm, you memorize the norm. Yes, you have. So that is embedded in your DNA, normal BP. So now once we're past our, 120 systolic and 80 diastolic, you're considered to have elevated blood pressure. But here's the thing you need to remember as well, everyone. Everybody has a baseline, right? So we need to establish our patient's baseline before we say, okay, somebody's hypertensive, right? Because I'll use me as an example. I generally run low with my blood pressure. Literally, I don't think my blood pressure has ever been higher than 110/70, and that's my norm. Um, the only time it was, postpartum. I had some hypertension, but that's different. So generally happening, my blood pressure normally runs low. So you need to figure out the person's, norm. So that's important too. But you're considered to have elevated blood pressure once you're between the 120/20, 120 through 29 systolic, and over, 80 diastolic, but we do need to establish the person's norm. Now, there are different levels to hypertension, or stages rather is the proper term, stage 1 versus stage 2. And of course, clients could go into crises, and certain disorders that we've already covered would cause that. So you do need to memorize this a little bit. So once we're at the 139/89, then you're at stage 1. Once you're over 140 and 90, you're at stage 2, okay? So keep those in mind as far as the stage 1 versus stage 2. So there are protocols, right? Whenever we're dealing with hypertension. So there are some lab works we're going to do that are just, routine. So there's routine lab tests that's recommended the moment we're thinking, hypertension, or trying to diagnose it or even treat it. Because the reason why this is so important, and we have to be aggressive and proactive, even, preventative measures are the best way. But if we're there, the reason is because of the tissue damage that happens if your blood pressure remains high. Okay, so we want to treat that or prevent it to begin with to decrease tissue damage, okay? And we'll talk about the risk factors in a moment. That's where we tie up the whole preventative measure, okay? So normally, routinely, the physician will order urine analysis, okay? And we'll do a CBC, we'll pull a chemistry panel. And these things do need to be fasting. So in the morning is best because we don't want people going all day without eating. We want to pull the total cholesterol. We're going to talk about the good and bad, right? Or we might have already done that. And of course, in ECG, so those are routine, right? That's what we call routine. Everybody's going to get this done. So that's the beginning phase. So hypertension is considered a disorder of the circulatory system because it is, okay? So once we have a systolic blood pressure of 140 or higher and a diastolic of 90 or higher, the client does need to be on some type of antihypertensives. Now, we've talked about us being least to most. We've talked about that. Okay, that's how we are in nursing. So at the beginning phase of that, we want to do the non-pharmacological measures, the non-pharmacological intervention, meaning no drugs. We want you to change your diet, lose weight, add regular exercise. Yes, that's all true. We do want all of that. But once you're at this state of, over 140 and over 90, then yes, we need some antihypertensives, okay? And chronic hypertension of pregnancy, we covered in OB, but especially if that high blood pressure is presenting itself before the woman is even at 20 weeks of gestation, very dangerous. We don't want somebody staying in that state. There's another term called accelerated hypertension. That is a crisis. Okay, you saw the chart earlier. We can't ignore that, because then a stroke is coming, which is what we want to prevent. Okay, there are guidelines, okay, to treating hypertension. We're going to talk about those guidelines because that's where your test questions will come from, right? Because remember, NCSBN goes by these type of measures. It's not something, that's opinionated. We have to go by the black and white. Okay, so you want to keep the black and white in mind when you're answering these questions, because if we go into the real world, what's happening in real life, every client is different. This is individualized. But let's learn what the book says, the general treatment for hypertension, because we're about answering questions correct. And that does show the test makers you're safe to practice. That's why we're always focusing on the black and white, the black and white. I can always deviate and talk to you about what I see in real life, but that's not going to help you pass NCLEX. So there are a lot of underlying factors that causes the hypertension. So we'll talk about primary versus secondary hypertension. So with primary hypertension, that is hypertension where it's not being caused by another disorder, right? The client does not have diabetes or Cushing's, or they're not pregnant, right? So primary, okay, doesn't have an underlying cause. Nothing else is causing it. The client is hypertensive without an underlying cause. Okay, so possible risk factors to hypertension in general, there's some familial tendency to that. It runs in the family, if we're speaking layman's term, right? That's what I mean by the familial tendency. It runs in the family, okay? Or it could be a cultural, right? Now, pay attention to that, everyone. Whenever you're studying and there's a little culture tag, you have to process that. You have to pay attention to that, because there are risk factor questions where literally they give you 4 clients and they'll ask you who's most at risk here for hypertension. Or they'll give you 4 clients and they'll ask you who has the most. You have to count the number of risk factors. So pay attention here for me. For hypertension, it is the African Americans, the Hispanic, the Native Americans that are more susceptible to this, that are more prone to this, that are because of and who can change that, right? We've already talked about non-modifiable factors. That is a non-modifiable factor. You can't change that, okay? But that's a risk factor. Obesity, we've talked about when we did coronary artery disease. 20% more than ideal weight puts you at risk. Diet that's high in salt, processed food, right? Canned, smoked. That's how it's preserved, with the salt. So they're very high in salt. A sedimentary lifestyle, which we've talked about before, is a lifestyle that does not include exercise. And of course, smoking. And those who are on hormonal contraceptives. Okay, and getting old. So lots and lots of risk factors. Please don't forget the risk factors, because this question comes at you a couple different ways. So be familiar with different risk factors. Now, secondary hypertension is being caused by another underlying condition, whether it be thyroid, a pituitary problem. I mentioned pregnancy earlier, coarctation of the aorta. You see the list here. So that would be secondary, okay? Okay. So now, I mentioned earlier that you can't diagnose hypertension, though the physician, remember, we always have to stay within our scope of practice. So the physician cannot diagnose hypertension with one take of the client's blood pressure. This is going to be based on the average of 2 or more readings, okay? Some physicians may even order it sitting down, sitting up, depending on what we're looking at. We want them, at least minutes apart, different arms, and then we're going to compare. Okay. So there's a test question that deals with the cuff size. I don't know if you've encountered that question. It's very interesting. So there's a silly little thing I want you to remember. It's silly, but it's not. I'm going to come right back. Don't forget, there's also a skill portion to the NCLEX, right? I haven't heard this question in a while, but it's coming to my mind for a reason. So I don't know if one of you needs to hear this or somebody's going to get this question in the future. But there's a very simple skill question where they're testing to see that you know how to properly take a blood pressure. And here's the issue with this question. A lot of you did this a long time ago. And those of you who you did this a long time ago or you were in school and you haven't been in the field, forgot. It's just that simple, you forgot. So let's go over this. So number one, we need to use appropriate cuff size. Too small is not good. Too large is not good. It needs to circle at least 80% of the client's arm. If it's too small, you're going to get a false elevated high blood pressure. Too large, false low. You need the right size, which is a silly little thing, right? Because if not, we're not getting proper reading, and you may be treating somebody for hypertension who's not really hypertensive. That's a problem. You want to inflate the cuff at least 30 millimeters above the palpated systolic blood pressure, which, here's where I want to pause. The proper way to do a blood pressure is to first establish, right? You want to first establish the palpated systolic blood pressure, which in real life, we skip this. This is another good section to remind you to go by the book. Don't go by what you see or what you're doing at the bedside, because unfortunately, there are areas where it's not by the book. You know, we don't do this like this. We just inflate to 200 and deflate, which is terrible. But you need to know the book. What you do, at the bedside, yes. Just if you're not doing it by the book, please let's go by the book. Okay? An accurate inflation level produces a false low systolic pressure. Cough should be deflated at a 2 to 3 mil. And this is a select all that apply, folks. That's why I'm spending a minute there. If you're deflating too slowly, that's a problem. You'll get a false high. Too quickly, you get a false low. So recap. If the cuff size is too small, you get a false high. If it's too large, you get a false low. You should always establish, okay, your palpated systolic blood pressure before you inflate 30 millimeters above that. That inaccuracy will cause a false high or low. And deflating too quickly or too slowly will cause false results. So pay attention to that, okay? Nice question, silly, but nice, okay? So let's go back. Just to recap, we talked about primary hypertension, we talked about secondary hypertension, pregnancy induced is covered under OB, and crises, accelerated hypertension is when the client is in crises, okay? You are memorizing stage 1 versus stage 2, and stage 3, they're in crises, okay? So that's your recap. Okay, now let's treat this thing, right? Let's talk about management of this. This is very important. The yellow here, that's a little, I'll have to change that color, says initial therapy, but let's start from the top. How do we manage hypertension? We also, in management of hypertension, are from least to most, right? There's initial treatment, okay? Especially if we're talking stage 1, uncomplicated, we don't have a whole lot of, abnormalities with this client. we would want them to modify their lifestyle. We would want them to add exercise if they're not exercising. Start by walking the block, right? Getting on the treadmill for 10, 15, 20 minutes, right? Walking and decreasing sodium, right? That's what we mean by, initial. Now, if those fail to decrease the client's blood pressure, then we go pharmacological. Okay, so first we start with non-pharmacological, then we go pharmacological. Okay, if the lifestyle modification does not work. So if we do have to do pharmacological, initial therapy right here is usually a thiazide diuretic, which we'll talk about in a moment. We'll talk about the electrolytes impacted by these diuretics with a combination of a beta blocker. We'll talk about the beta blockers, the ACE inhibitors. We're going to talk and break down these medications in one moment. So if the client has a history of heart failure, left-sided heart failure right here, and they're a diabetic, the ACE inhibitors are the first choice. So pay attention to your client's history and what's going on with the client. I've spoken with you about diabetics before. They're very difficult to treat. So the moment in your question you get a diabetic and a glaucoma, those two clients, your antennas have to be going up, especially when it comes to medication, because there's so many contraindications with these two clients, diabetics and glaucomas, okay? So in your question, you get a client who has a history of left-sided heart failure and or they're diabetic and we need to treat their hypertension. It's going to be a pril, right? We'll talk about the ACE inhibitors. It's going to be an ACE inhibitor. Most of them end in pril. That's why I just said that. Goal of treatment, we want to prevent that organ damage that I mentioned earlier. And that's why we're so aggressive with making sure we keep your blood pressure low, because as it increases and increases, you're at risk of damaging your organs. Okay, so we want to keep your BP less than 130/85. We want to control your cholesterol. Okay, if you're obese, we want you to lose weight. We want you to exercise. We want to control your blood sugar. Okay, lots and lots and lots of teaching concerning this, and you could see the teaching and learning questions. So as you're learning this, you're thinking of how do you teach this to the client? What's the best thing, the priority thing to make sure the client knows as they're being prescribed these medications or being diagnosed with hypertension, okay? So we're coming to the end of the cardiac system. Some of these drugs we've already covered. So this is going to be a nice recap. Recaps are good because they reinforce the information, okay? So this is a picture of the different family or class of drugs, right? So the antihypertensives are a family, right? Class of drugs that you need to know and be aware of for this system. We're going to talk about the renin, angiotensin, aldosterone system, RAS, and two cousins. I like to talk about drugs in the sense of family, falls under the RAS, okay? Pocket that. Beta blockers, we're going to break down. The calcium channel blockers, we're going to break down. The diuretics, we're going to break down. We talked a little bit about the statins before. We'll do a little bit more in detail here. Okay, your dyslipidemias, we're going to talk about. Antiplatelets, you see it's a lot, so we couldn't have covered that in such a short time. And I want to take my time. I don't want to rush covering this, okay? So hopefully you're taking notes and you're processing this, and we'll go slow. Okay, so you're not overwhelmed, but we do need to have, a good grasp of all of these drugs. Okay, so let's start from the beginning with the RAS. So RAS stands for renin, angiotensin. So we're going to talk about the kidneys just by me saying that. Aldosterone system, renin, angiotensin, aldosterone system. So I want you to know what the acronyms stand for, because it's going to make sense how these drugs are lowering blood pressure, right? Antihypertensive against blood pressure. So the problem is that elevated blood pressure, but we need to figure out what's causing that blood pressure to go up? There are several ways, several causes of why somebody's blood pressure is elevated, okay? So one way the blood pressure goes up is via what we call angiotensin. So angiotensin elevates blood pressure. So your RAS is going to block angiotensin. And that's how we're going to lower the blood pressure. There are two categories of RAS. There's the ACE inhibitors, which stands for angiotensin converting enzyme inhibitor. So it's going to stop that angiotensin, and that's how it lowers the blood pressure. And then there's ARBs. And here's what ARBs stands for: angiotensin receptor blockers. So they're both stopping angiotensin, and that is how they're going to lower the blood pressure. So if that is the pathophysiological way that this client's blood pressure is elevated, this is the way to stop it. Okay, so both can be used for hypertension, which we're talking about, heart failure, chronic kidney disease. If the blood pressure is due to increased pressure in the kidney, this is going to decrease the pressure in the kidney. So your RAS, which are your ACE inhibitors, angiotensin converting enzyme inhibitor, ACE, or ARBs, angiotensin receptor blockers, are going to block angiotensin to lower the blood pressure. Now, the whole family of antihypertensives mess with our electrolytes. You have to remember that. So if you get a question that just says the client is on an antihypertensive, that's the whole family. Electrolytes have to be crossing your mind. Now, if I give you a specific antihypertensive or a specific diuretic, then you need to attach that. And by the way, everyone, that is how you study pharmacology. You have to first know the class of drugs. The moment you get a question that tells you they're on an antihypertensive, that's the class of the drug. You need to know adverse effect to the entire class, meaning it doesn't matter which antihypertensive. In general, here's another example. We've covered anticoagulants already. So if I tell you the client is on an anticoagulant, it doesn't matter which one. They all cause bleeding. So that's how you have to study pharm. First, study the class and the adverse effect to the class. Don't jump directly to specific drugs. You got to make your way to that, okay? So watch the pharm recording for that part. But let's get back to antihypertensives. So I color coordinate. If you're colorblind, you may not be able to see this. If you're colorblind, all the prils are in red and all the ARBs are in this pretty purple. Okay, so your ACE inhibitors, well, let's go back. Let's go over the effect, which is where I'm at. So you know they're going to lower blood pressure. Now, please think of things as in a spectrum. And what do I mean by a spectrum? So imagine a ruler, right? Imagine a stick. There's two ends of it. So we're treating hypertension, but we're going to watch out for hypotension. Okay, so always think on a spectrum. And I see questions like that, questions after question after questions like that. And then next gen now does this to you, right? Next gen wants to know that you know your client is getting better, but what happens if the client is now going into a hypo? And that is what you need to be looking for. So sometimes in your questions, you always have to ask yourself, are you pre-treatment or post-treatment? Are you pre-surgery or post-surgery? Because if you're pre, then you're dealing with the disorder, right? You're dealing with the disease, you're dealing with the problem. But if you're post-treatment, post-surgery, you're dealing with the other end of that spectrum. That is so true with the endocrine system, everyone. Yes, we may be dealing with hyper, but if you're after surgery or you're treating it, you're looking out for hypo. Same thing here. We're treating hypertension, right? We're giving all these antihypertensives. We better be looking out for hypo, okay? And monitoring the client, because they could bottom out on you. Maybe you treat them too well, right? We want to treat them at the right amount. Okay, so the effects are hypotension, a decrease in the blood pressure. You're looking out for that. And the RAS family, they hold on to potassium. They cause an increase in hyperkalemia. And a little something we call angioedema. Now you see edema, so you know there's swelling. Where is it happening? Around the face and the throat. They look like the raccoons. I don't know if you've seen those pictures. Edema around facial area and throat. Now, the word only is an absolute. So you're waking up because you've watched my test taking strategies and you are not reading an absolute and for it to not be popping up at you. Only the ACE inhibitors cause that nasty dry cough. All day the client is all day. And the reason that's happening because it increases a little peptide we call bradykinin. Okay? And they're also pregnancy category D. So if the client is pregnant, this is not the option for them. Recap. The entire RAS, it doesn't matter if it's an ACE inhibitor or ARBs, are going to cause hypotension, hyperkalemia. But your ACE, the prils, lisinopril, enalapril, ramipril, the prils cause the dry, nasty cough. Don't mix them, please. Find a way to remember that. ACE has a C, cough has a C. I don't know if that helps. Hopefully it does. So these are your prils right here, okay? And do work on generic names, not brand names. So sometimes we'll combine a ACE inhibitor with a diuretic. So lisinopril combined with hydrochlorothiazide, which is Premzide. It's a combo drug. Okay, obviously, these are for maintenance, Q-Day. Now, your ARBs and then sartan, which helps. Losartan, almosartan, valsartan. Okay, so you should be good with your RAS. Okay, if minimally, you should be able to classify them under the right drug classification. All right, so now let's go to the beta blockers. Okay, nice family of drugs. So let's go over another way your blood pressure goes up, okay? Another way clients end up hypertensive is due to release of adrenergics from the adrenal glands that sits on top of the kidneys, right? You have two kidneys, you have two of them. So if you remember your endocrine system, this is where this is covered in detail, right? We have two kidneys, and on top of each kidney sits the adrenal gland, which has an outer cortex and an inner medulla. I don't know if you remember all of that. The job of the outer cortex is to release and control epi and norepinephrine. So sometimes that is how the client's blood pressure is going up. Your sympathetic nervous system, remember your fight and flight, that's what we're talking about here. So the blood pressure goes up when these two are released, epi and norepi. So the beta blockers are antagonists to epi and norepi. They're the enemies. They're going to block them, antagonistic, right? Against. So once we administer these beta blockers, they're going to lower the blood pressure if it's being caused in that way. So great for hypertensive clients who are releasing epi and norepi. Great for anginas, which we've covered already. Atrial fibrillation, which we've covered already, and we talked about the beta blockers then. You see how all of this is coming together? Post a heart attack, You see how all of this is coming together. We talked about atrial fibrillation and beta blockers. Now, the entire family has box warning. We never, ever, 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 ever. This is an absolute. We just saw an absolute only, right? With your ACE, with the coughing. Here's another absolute. Never abruptly stop these drugs, because your body does something we call a rebound effect. Every day you've been giving me this drug and all of a sudden nothing. So your body's going to try and compensate for this. And you're going to end up what we call a rebound tachy, right? Your heart's going to start racing, and then a rebound hypertension. Your beta blockers are broken down into 3 subcategories. This is important. This is where critical thinking comes in. This is your higher level questions, everyone. So wake up right here, okay? You're getting these questions correct, you're most likely to get the minimum amount of question and then clicks and get the heck out of there. So beta blockers are broken into 3 subcategories. A1, right, your arterioles. That's the route where they're working. The B1, the heart itself, and B2, the lungs. Okay? Now, what you need to keep in mind are the beta blockers that affect all 3. And we call them non-selective. They don't discriminate. That is what's happening. They don't discriminate. So let's go over the B1s first, because they're most prevalent or popular. And they end in alol, which is great. Okay, atenolol, metoprolol, okay, which helps. We love that. It makes life a little bit easier. So those will work directly in the heart, right? B1s. Your mebivolol is a combo, okay, with the arterial in the heart. Okay, so it's going to work both. It's going to have a B1 cardiac effect, and it's going to have a A1 arterial. And the way it lowers the blood pressure is via dilation. It's going to open it. So if we see that's what's going on, then yeah, nebivolol is the best drug. And the bistolol is a great way for you to remember that, because bi means 2. Nebi, bi, right? I hope that helps. I always find sometimes there's not much to pull out to help you remember something. You'll just have to do repetition. But if we can find something, find it, right? And your propranolol and carvedilol are very special drugs, right? Inderal and Coreg, we don't play with these drugs. Great for heart failure, migraine, but the problem with them is they're non-selective. They're gonna have an A1, B1, B2 effect. So if you have a client with a respiratory condition or history of, this is not the drug for them, right? It's going to affect heart rate, contractibility, and respiratory. It causes bronchospasm. It's going to also mask hypoglycemia. And your diabetics. I mentioned the diabetics before, right? You're always processing these diabetics and glaucoma clients, okay? So please, propranolol, okay, and carvedilol, you get these in your NCLEX questions, wake up. Process that they are non-selective. So look for history of respiratory problems, and they're contraindicated with these clients. I'm moving super slow. I feel like I need to recap. I was just about to go next, but let's recap. So sometimes the client's blood pressure is being elevated due to a release of epi and norepinephrine. So beta blockers are antagonists to epi and norepi. So they're the ones we need to use to lower that client's blood pressure. Okay, and they have 3 subcategories, where they work in the arterial, in the heart, and in the lungs. So your alols, atenolol, and metoprolol, whether it be titrate or succinate, they're going to work directly in the B1, the heart. Nebivolol has a combo effect where it works in the arteries and the heart. And propranolol and carvedilol are non-selective. It's going to affect all three. And the whole family has a box warning of never abruptly stopping them. Okay? Let's try this question. A client is getting ready to go home after a myocardial infarction. The client is asking questions about his medication and wants to know why metoprolol, Lopressor, was prescribed. The nurse's best response would be which of the following? Give you about 10 seconds to process this one. And you can send your answers within the classroom or the chat. Now, a couple of test-taking strategies. So we've talked about, you're not stressing the heart and everything, but what I want to add here is whenever you're answering these type of questions where the nurse is speaking back to the client, you want to always use layman's term, right? Like you're speaking to a friend or something, because if you use medical terminology or jargon they don't understand, then you're wasting time because the client's just going to be like, huh? What does that mean? And more questions after questions, right? So keep that in mind. That's a nice little test-taking strategy when you're responding to a client, okay? All right, so hopefully you went with 4. Let's go over that. It's going to slow your heart rate and decrease the amount of work the heart has to do so it can heal. That's a layman's term way of letting the client know how metoprolol works. We just talked about it being a beta blocker. We talked about it lowering the blood pressure, okay, and working on the heart rate, my little less than sign. By the way, if you're not familiar with those, I should have mentioned that. So to the left is less than, to the right is greater than, okay? So the main therapeutic effect of an MI is to reduce cardiac workload. So this would be great for these clients, okay? It's not going to dilate the coronary arteries. And it decreases contractibility. This is a nice typical, I like how this just gives you an idea of one angle that these type of questions could come at you. Now, I want to remind you, let me go back real quick, of the whole coughing thing with the ACE inhibitors. That's another angle this could come at you. This could come at you as well, where you need to know their use, right? So this is a question, the one I just threw at you was with the use, right? With the cardiac effect, increasing the heart rate. It could come at you where the client has a history of asthma, bronchitis, where you need to remember about the non-selective. So as you're studying, you want to think of how would this question be posed to you. So the one I just gave you was on the metoprolol, you knowing about the cardiac effect, not really the arterial. But if I change that question to nebivolol, you need to know the arterial effect, right? So you want to study where you're replacing this, right? See, like, okay, this question could come at me where, they don't give me a lol. They give me, I'm sorry, they don't give me metoprolol, they give me nebivolol, or okay, they switch that now to propranolol. I could make this question with any of these drugs, and I'm testing to see that you know which ones work on the arteries, which ones work on the heart, which ones work on the lungs. And if I were to switch this to let's say propranolol, I would make the client have a history of some type of respiratory problem to see if you know that content. So you see how you should study. So when you're studying, you're thinking that way. And then when you do your rationale, that's where you learn some of these, other angles that the question may come at you. So let me take a pause right there and remind you after you take these exams that I have under each client needs categories, you must remediate them. At the end, it asks you if you want to review your test. The answer is yes. And go over your answer and the answer and why that's the answer. That is what we mean by remediation. And you want to do that for every question, not just the ones you get correct, because the ones you get correct, you can reinforce good behavior, good knowledge, but the ones you get incorrect, you want to fix the damage, okay? All right, I feel like I'm drilling you. All right, let's move forward. We'll cover a couple more, then we'll do a breather, okay? So that this is effective. So let's go over the calcium channel blockers, okay? Most of them, not all, but most of them end in depine, which we love. Okay, let's go over another way your blood pressure rises. Okay, so we've covered two formats already of how your blood pressure rises, the angiotensin and the epinephrine and norepinephrine. Now here's another way, another possible cause of hypertension in a client. We have calcium in our arteries, okay? In the heart, your SA node and the AV node, which we've covered in detail. I hope you enjoy my anatomy of that. So we have calcium in our arteries, in the SA and AV nodes of our heart. They cause vasoconstriction. That vasoconstriction causes an increase in blood pressure and heart rate. So one more time. Another way hypertension happens is due to that calcium that is in the arteries of our hearts, in the SA and AV node. They cause vasoconstriction, that closing, that tightening. That vasoconstriction causes hypertension and an increase in heart rate. So your calcium channel blockers block that calcium, literally. And because it does that, it will lower the blood pressure and the heart rate. Great for hypertension. Great for angina. Great for AFib. Okay? Now, anytime we're talking vasodilation, prepare for a headache. It's just the nature of the beast. Okay? So some adverse effects, teach the client, headache, flushing, dizziness. By the way, the whole family of antihypertensives, you're at risk of orthostatic hypotension. So you know what goes with that. Mrs. Jones, don't get up without me. When you get up from a lying to a sitting, stay there for 5 minutes. When you go from a sitting to a standing, stand for 5 minutes. Literally, like you're like a robot. The moment you put clients on these drugs, you're teaching this stuff because they don't know any better. They get up too quick, the room spins and boom, they're on the floor, concussion. Let's avoid that. Not a good thing to be happening. Okay? Unfortunately, you see the whole category and subcategory thing. It's just the way it is. Okay, so your calcium channel blockers have two subcategories, okay? One category is what we call the dihydropyridine. Here is the absolute. They only work on the vascular system. So they're only going to lower the blood pressure, but not the heart rate. Okay? So if a client has both problems, nifedipine, amlodipine is not for them because this is not going to have any effect on the heart rate. So repeat. Your dihydropyridines, those calcium channel blockers, only lower the blood pressure. They don't affect heart rate. They don't lower the heart rate. Okay? That's nifedipine, the pines. Procardia, Norvasc. Remember, generic names are what you're working on. But your none, okay, none, dihydropyridines, they work on both. They're going to lower the blood pressure and the heart rate. Diltiazem and verapamil. Okay. So you see how, and I see why in Next Gen, you would get the chart with the client's vitals. And you need to pay attention if you have a hypertensive client with a normal heart rate. So if they're hypertensive with a normal heart rate, you're going to see nifedipine, amlodipine, right? Could be a combo with an amlodipine and a ACE inhibitor. That's a combo drug, Lotrel. But you're not going to see diltiazem because then their heart rate's going to go down too low. That's a problem. But if they have both, where they're hypertensive, right, with an elevated heart rate, then yeah, verapamil, great. Diltiazem, great. Again, these are higher level questions, everyone. So you have to, I know some of you are probably at work listening to this, which is fine, but you need to listen to this again in a secluded, comfort, no noise, right? Where you can zone in and process what I'm saying. Because this requires attention in order for you to lock it in. And when we practice questions, we'll see if this is, connected. And that's how you know you'll get it, when you're getting questions correct and you remember the reason why, you remember the rationale, right? Why wouldn't I give diltiazem to this client? Oh, because their heart rate's within normal range. Why wouldn't I give verapamil? Oh, because their heart rate's within normal range. Because remember, now these days with clinical judgment, they want to see that you know how this is going to be treated. Yeah, we're not prescribing, but you still get questions where you need to know the treatment and the priority treatment. Okay, so recap. Your calcium channel blockers, they're going to lower the blood pressure by blocking calcium, okay, which are in the arteries, the SANAV node in the heart, which causes vasoconstriction. So they're going to block that, okay, to cause the vasodilation. Expect the headache, the flushing, the dizziness. So safety is a factor with all these drugs, okay? And the pines only work in lowering the blood pressure. They don't affect the heart rate. Okay, but diltiazem and verapamil, both. One more and then we'll do a mental break. Hang in there. Your diuretics, which you also know as your water pills, okay? Always in the morning because they make you pee. If you give this at night, the client's going to be up all night urinating. That's mean. Don't do it. Take in the morning because they work on the kidneys. And water follows sodium. Okay? Clients should always be hydrated when they're on this drug because think about it. You putting out a lot of fluid. You got to replace it. So they need to be taught. Stay hydrated. Drink a lot of water. Walk around with your bottle of water. So because an adverse effect is dehydration. It's going to decrease the blood pressure, which is going to cause the dizziness, acute kidney disease, electrolyte imbalance, which is going to cause muscle cramping. And you know there are subcategories. You kind of knew I was going to say that because that's been the trend, right? So same thing, your diuretics have subcategories. There are your thiazides, there are your loops, and there are your aldosterone antagonist, which hold potassium. We'll talk about that in a moment. So let's do thiazide first. So the thiazide diuretics we would use for your hypertensives, heart failure, and edema clients. It's going to lower the blood pressure, pull out all that fluid. Their kidneys are working beautifully. They're going to urinate all of that out, especially right-sided heart failure. We would use the loops if we're just dealing with the edema. Okay? And your aldosterone antagonists are great, especially if the client is on digoxin, because remember, we never want clients hypokalemic on digoxin. Great for heart failure, edema, hypertension. So let's go over the specific drugs. So your thiazide diuretics you want to be familiar with are hydrochlorothiazide and metolazone. So hydrochlorothiazide, the client will be wasting, putting out, peeing the sodium, the potassium, the chloride. So they're going to be hypo on all three, hyponatremic, hypokalemic, hypo. But unfortunately, it's going to hold on to sugar. So they're at risk of hyperglycemia, hypercalcemia, and they could be at risk of gout, holding on to all that uric acid. So one more time. Thiazide diuretics, like hydrochlorothiazide, hold on to all of these electrolytes. Sodium, potassium, chloride. I'm sorry, waste. They pee it. Waste. Sodium, potassium, chloride. So hyponatremia, hypokalemia. Now, let me connect something. So we talked about digoxin in the past to death. And you know we never want a client on digoxin and hypokalemic. So you don't ever want to see a client on digoxin and hydrochlorothiazide, because they're going to be hypokalemic, which is going to make them toxic under digoxin. Nice high-level question. Don't want to see that. And I'm going to monitor their blood sugar because of what this diuretic does. I'm going to be pulling a chemistry panel. Obviously, we are. And they should be on a diet low in calcium, right? High in sodium, potassium chloride, lots of fluid, but low in calcium, and food that are low in purine, right? That needs to be their new diet because you're already holding on to it. Imagine you holding on to it and you're adding. Problem. Okay. Let's go to your loop diuretics. You should be very familiar with furosemide, but the three loops you need to be familiar with are furosemide, torsemide, and bermutinide. Okay, ide. So these great for the edema, the heart failure, but not for the hypertension. Right? Great to remove the fluid, but these are like, that would not be the only drug the client is on if we're trying to lower their blood pressure. Okay, and they're wasting so much electrolyte, sodium, chloride, potassium, mag, calcium, and acidic ions. Yeah, nasty. You know spironolactone is special, you know that. So this is the one electrolyte that is holding on to potassium. So this electrolyte is safe to administer with digoxin. Okay, but it also causes these not so nice effects. They have this anti-androgen effect, we call, okay, which causes gynecomastia, the enlarged breast in men, and some sexual dysfunctions. Not a nice drug because of that, but then sometimes that may be the option. Okay. Oh, recap. Your diuretics, always in the morning. Tell the client to stay hydrated. Okay. They work on the kidneys to lower the blood pressure, to fix the heart failure by removing all that excess fluid and the edema. And there's three subcategories: thiazide, loop, and aldosterone. Okay, antagonists. So your thiazide are hydrochlorothiazide and metolazone. They waste sodium, potassium chloride, but they hold on to sugar, calcium, and uric acid. Your loops, not good for hypertension. The edema, yes. Removing of the fluid, yes. Spironolactone holds on to potassium. So we can mix those with digoxin. So all of that I've just did are test questions. And don't forget the little nasty gynecomastia in men with spironolactone, questions about that as well. Okay. All right. Mini mental break. Okay. Mini mental break. Bathroom, snack. Come right back. All right, everyone. So quick recap, because we've covered quite a bit already. So you should be good with the RAS, right? Your ACE and your ARBs. You should be good with your beta blockers, all the subcategories, your calcium channel blockers, and your diuretics. So we've covered those so far, okay? So remember, your renin-angiotensin has the ACE inhibitors and the ARBs. Your ACE and then pril, they're the ones who cause that nasty chronic dry cough, okay? And as far as test questions, you need to remember that. You also need to remember the effect on the potassium, okay? They cause hyperkalemia, your RAS, okay? And your beta blockers has 3 subcategories. They work on your arteries, your heart, and your lungs. Don't forget the non-selectives. They don't discriminate. You need to assess for respiratory concerns with those. And your calcium channel blockers have the dihydropyridine and the non-dihydropyridines. So the dihydropyridines don't work on the heart rate, but the your diltiazem and your verapamils do. Okay, your diuretics, you need to know which electrolytes are impacted. So some of them will waste the electrolyte, causing the client to be hypo, and some will hold on to the electrolytes, causing the clients to be hyper. They're always given in the morning. Okay, so now we are on the statins. Okay, so why are we giving these family of drugs? Why are we administering them? So we're only administering them if the client's cholesterol, right, lipids are high. So hyperlipidemia is where you'll see these medications being administered. Now, the thing is, they work in several ways. I don't see many questions asking about the patho of how these work, so but it's just good information to know. So they work in more than one way to lower the bad cholesterol, the lousy, right? We've talked about HDL, LDL, and total cholesterol. So of course we're targeting the LDL, the lousy, the bad cholesterol, because they're the ones who attach, right, to the wall, and they accumulate, and they block the way so that blood cannot continue to go to the other side. So great use for preventative measures to prevent some of the cardiovascular diseases we've talked about already. Great to lower the LDL, the hyperlipidemia. Okay, we do give them at night. Why? Because the body is sensitizing cholesterol in the night. You saw with the diuretics, that's in the morning. Here's the opposite here. Statins are at night. Okay? There are some adverse effects to these drugs, and you need to be familiar with them. Muscle pain. Be familiar with this word, rhabdomyolysis. Okay? That is muscle breakdown. So if the client is experiencing this adverse effect, one of the first ways we look to make sure that is happening, to confirm that, is via the urine. If you're breaking down muscle, okay, the urine is going to be dark. So that's why we want to collect those urine analysis frequently, protocol. So muscle pain, rhabdomyolysis, muscle breakdown is going to cause that dark urine color. Okay, that's that excess protein being broken down. Not good for the kidneys, by the way. That's going to put a lot of stress on the kidneys. Okay, we're going to stop the statin. Okay, we're going to look for that enzyme by pulling that CPK. we're going to look for that enzyme. We're going to do a full liver function test panel, okay? And we look for hepatotoxicity, right? And again, if anything is affecting organ, this is serious, right? That's why these questions are considered higher level, because if we don't catch them or we're not aggressive with them, we don't do something about it, then clients end up worse and could potentially die. And we're never giving statins if the client is pregnant. That's a category X, right? So research shows for sure this affects the unborn child. So you see, there's a lot to know about your statins. Don't underestimate them, okay? So recap, they're going to work on reducing that lousy, right? That LDL, lousy cholesterol that attaches to the walls and accumulates. Okay, always given at night. These adverse effects are nasty. Rhabdomyolysis is nasty. That's muscle breakdown. The urine's going to be dark. The drug does need to be stopped at that point. And we're going to look at the liver. We're going to look at the kidneys. And if you're pregnant, that's not the drug for you. The great news is that most of them end in statin, pravastatin, simvastatin. We love that, right? Makes life a little bit easier, okay? So Lipitor, we definitely avoid in pregnancy, okay? Simvastatin works more in the GI tract, okay? Rosuvastatin is very potent. You don't see questions on those, that's just FYI. Now, there's one more thing I want to add that's not on this PowerPoint. Whenever we put client on statins, one of the things that we want to monitor is their fat soluble vitamins. I hope you remember ADEK. So if you don't, ADEK, ADEK. So ADEK are your fat soluble vitamins. Now, as you lower this client's cholesterol with these drugs, there's a potential of lowering these fat soluble vitamins. So they need to be replaced. Okay, so we want to monitor and make sure we're not depleting the client of the fat soluble vitamins, which is ADEK. Water soluble are your B complexes and vitamin C. Those are water soluble, okay? But your fat solubles, ADEK, you want to watch when you put a client on statins, okay? Now, a couple other agents for dyslipidemia, for any type of abnormal lipids, the problem with those, or the pathway with those, they're going to work on both the good and the bad, right? So we want to watch and make sure we don't deplete them of the HDL too much, right? They work on the triglycerides, okay? Fenofibrate and gemfibrozil, okay? So with those, you're going to monitor the HDL and the fat soluble vitamins. These are natural, the omega-3s you're probably very familiar with, great. They're regulated by the FDA. With niacin, there is a nice question on the NCLEX about the pruritus. You want to warn the client about that, right? Zitia has a nice commercial, ezetimibe. It's going to block that dietary cholesterol, that intake that the client is probably overdoing. Not many questions on cholesterol, but works in the gut to decrease that LDL. And the client should be very hydrated on this one, okay? And we wouldn't want to give these with other medications, so they should be at least 2 hours apart, and they should stay hydrated. So a few little craziness you need to remember about your fibrates that works on the triglycerides. Stay hydrated, and they should do other measures to prevent constipation, like walking, right, eating fiber, right? All these little good habits will prevent, or the constipation won't be as bad if they add these measures, okay? Okay, next family of drugs are your antiplatelets. Okay, so these are for preventative, right? Go home and take. Those wouldn't be for acute. So post a heart attack or stroke, the client may be prescribed aspirin, right? 81 milligrams Q-day for however long. So there are two classes as well, your COX-1s and your COX-2s. So your COX-1 are going to prevent that clotting. That's their purpose. Your COX-2s are more for pain, inflammation, and fever, right? Would be why we would give those. But again, preventative measures to treat that heart attack and the stroke. And history. We always want to monitor history of things like GI bleed with these clients, right? Peptic ulcers. If they already have a history or they're at risk of, we may need to reconsider this. So the dose is monitored to prevent that tinnitus that may come with this family of drugs. So sometimes you'll see a mixture of aspirin and dipyridamole. You might be familiar with Agranox. They're in extended release. You already know what that means. Don't crush them, don't break them. If the client is on a peg, this is not the medication for them because you can't give it that route. Okay, so great for secondary stroke prevention. Of course, there's some vasodilation because of its combination. So headache is coming, right? It's just good to warn people. The grails, clopidogrel, prostagral, ticagrelol, right? The whole grail. I don't know if you're familiar with that suffix. Again, preventative for the MI, ischemic stroke. Bruising is an issue, so this is education, right? Teach the client, right? Don't come into contact, right? Because then they're gonna bruise. Your grail sometimes are used post stents, right? For long-term, not good for new strokes. Okay, they have box warning, all of them do. Okay. Not many test question. There's some risk of gynecomastia too with these, so the male clients. If you ever get a question where it tells you male or female, you're processing why. Why are they telling me that? Okay, like we saw with spinal lactone, that would be a concern if in my question I see a male client. You have to educate about the gynecomastia. Some people may not be able to mentally handle that. So teaching, lots of teaching here, not the higher level. It's either you know it or you don't know it. So you have to know it for you to be successful in getting these correct. So we've already spoken about these, but I can't help it. So we're going to just recap. Okay, recap is good, but we've already covered Coumadin, warfarin. We've covered enoxaparin. So this is a recap, okay? So they're anticoagulants, okay? They're going to stop clotting, but now let's talk about how do they do that, okay? They affect factor 10 and 2, okay? That's how they cause that bleeding or thin the blood, right? We talked about them when we talked about deep vein thrombus, when we talked about pulmonary embolism, obviously AFib, we talked about them during that time, but great for heart attacks and the valve replacement we talked about, okay? And we talked about their route. We talked about you memorizing the normal PT-INR, right? The normal INR 2 to 3. We talked about putting the client on fall precaution because of the bleeding. We talked about your antidote, staying away from green leafy veggies or not consuming excess amount of it, keeping the same diet where your INR was within 2 to 3. Okay, give them away from other drugs. We don't give them with other drugs. This is not for you if you're pregnant. It's okay if you're breastfeeding, but not if you're pregnant. Okay? So, and bleeding. Now, enoxaparin is a low molecular heparin. We talked about that. So there is no need to monitor PT, APTT, INR, no, because it's not going to thin your blood like that. And it works immediately. Okay, we give them, I showed you the picture of all the different places we give them, but most common place is the love handles around the umbilicus. So it's a class B category drug. The client would be at risk for thrombocytopenia, renal problems, but not a high percent of that. So this is recap, okay? We went over this not long ago. So some more anticoagulants, what we call novel oral anticoagulants, great for the DVTs, again, the AFib. So we talked about rivaroxaban already, right? Xarelto. We talked about Eliquis. You see Zaban. The Bigatron is a little bit different with the suffix, but same family of drugs. Now, these are not high maintenance. There is no need for routine blood work like you need with the Coumadin and warfarin. No need for these oral anticoagulants, the novel ones. They work immediately. Okay, the client excretes them with no problem. If they have no renal issue, then there's no problem with those. Okay, we're not using those for heart failures, but they're great drugs, otherwise for your AFib clients. Take with your evening meal type of thing. No special prep, no staying away from certain food, no blood work. So that makes them very low maintenance. And that's the reason why they're low maintenance like that. They're only working on one clotting factor. Okay, either 2 or 10. That's why they won't thin your blood like that, and they don't interact with vitamin K. So keep those things in mind. Okay. This is recap again, which is good. We talked about your anti-anginals, right? We talked about them being great vasodilators, especially while the client is experiencing these chest pain. Okay, they all cause headache. Whenever you're vasodilating, that's just goes with that. Vasodilation, headache, orthostatic hypotension, flushing, dizziness, all of it. I sounded like a broken record saying that again and again and again. There's nitrates and there's non-nitrates. We've talked about the nitrates, so this is recap, right? We talked about your sublinguals, the 5-minute, 3 doses, and then you better be in the ER. Okay, we talked about your non-nitrates. We talked about isosorbide, dinitrate, and mononitrate. We talked about those. So this is recap. These are for preventative, long-term. Okay. I don't think I mentioned ranolazine, but it's same family. Earlier, we talked about the whole calcium in the heart. So it's going to work on the sodium calcium in the heart, but not affecting BP or heart rate. So it's preventative for the chronic angina client. Okay. A few more cardiovascular medications we need to talk about specifically for heart failure. I mentioned amiodarone earlier in the cardiovascular system, so there it is again. So amiodarone we talked about when we did the EKG section. Okay, so if we're using those, these are critically ill client, we need what we call loading doses. Okay, so that would be prior to the maintenance dose. So we talked about amiodarone when we covered ventricular problems with the EKG. So great for ventricular arrhythmias. Okay, falls under different class. It's going to block potassium, sodium, even calcium in the heart. So if the client is allergic to iodine, that's a problem. That's why history, we must do a history, because this could very well be a mistake if we don't check that. So recap, amiodarone for ventricular arrhythmias. Remember, after we covered the atrial problems, we covered the ventricular problems, and this is where we brought the amiodarone. You see how everything is now coming back together. And the repetition is great. Box warnings. Pulmonary fibrosis, hepatotoxicity, arrhythmias. Not the drug. DIG, we talked about already. Recap. So I went over this again, but just for repetition's sake. Digoxin works on the vagus nerve, right, of the nervous system. That's how it's going to lower that heart rate and help the heart works better and not harder. Works on the SA and AV node to slow it down. Okay, to slow it down. Works on the sodium potassium pump to decrease how hard the heart works. You see how that will cause the heart to work better and not harder. We talked about them when we talked about the atrial arrhythmias and the heart failure. We talked about the digoxin. We talked about you memorizing the therapeutic range for DIG. Sorry, but yes, you already committed this to memory. You know how a client is going to look when they're toxic on the DIG, and you know if they're hypokalemia, they're going to be toxic on the digoxin because there are too many pumps left for the digoxin to bind to when you don't have enough potassium to bind to those pumps. Showed you a nice picture of that. That's the pathophysiological process that's happening with dig toxicity. They're going to be nauseous. They're going to be brady, not tachy, but bradycardic. They're going to have that halo vision, okay? Because you don't have enough potassium to bind to the pump, so then all the dig is going to bind to it. And when you pull that therapeutic range, it's going to be well above 2. If they have any renal problems, and that's not just for dig, that's in general, any type of acute renal, chronic renal, how is the drug going to get out? What goes in must come out. What goes in must come out. What goes in must come out. You putting dig and there's no way of it coming out? Yeah, you're going to be toxic. Okay? We always do a medication reconciliation. Okay? And you should be good with the ATPase pump with the hypokalemia. You see, I love when things repeat. Okay? So, recap, again, this is stuff we've already covered, but this is in a different way. So those of you who learn this way, it's the same thing, nothing different, okay? So the others, I have pictures and different colors. I try to do the coloring here too, because I think it helps you with the color so it pops out. But we've covered the ACE inhibitors, okay? We've covered how they cause hyperkalemia, how they cause the induced chronic cough, okay? Now, you would not mix an ACE inhibitor with a diuretic that holds onto potassium. That would be a problem. Expect hyperkalemia because you have 2 drugs holding onto potassium. That's a no-no. Okay? So your ACE inhibitors, hyperkalemia, induced chronic cough, do not mix with another potassium sparing or holding diuretic because they're holding onto potassium. Your calcium channel blockers, your dipines, they're going to decrease cardiac contractibility to decrease the workflow of the heart, making the heart to need less oxygen. Okay. And by the way, all these drugs, all of your antihypertensives, you're holding if the heart rate is below 60. And you're not giving it. Here's another test question I want to remind you of, specifically with the calcium channel blockers. I've mentioned it before in previous lectures. Calcium channel blockers do not mix with grapefruit and grapefruit juice. Okay? Like daltiazem. It's like you double dosing. It's going to the drug is going to be at a very dangerous level. And the other thing you need to remember about calcium channel blockers, they act a little bit like a male contraceptive. Okay, so that male contraceptive effect causes, if it's a young person who wants to get pregnant or have a child, then they won't be able to. Okay, so if it's a young person who wants to have a family, they shouldn't be on any calcium channel blockers. So a lot of recap. Okay. Cap again on the diuretics, don't mix them. So there are some other diuretics here that don't fall under hypertension, like osmotic diuretic would be for increased fluid in the brain, like mannitol, so that falls under another umbrella where we cover that, okay? And your carbonic anhydrase inhibitors, those diuretics we cover under fluoride electrolyte, right? They're covered under another umbrella. So the ones that fall under hypertension as antihypertensives are the thiazides, which we've covered, your loops, okay, your potassium sparing. So we've covered all of these, okay? I forgot my cursor's here. All of these. So these two fall under another umbrella, but they are diuretics, right? But for the antihypertensives, we've covered hydrochlorothiazide. And you see how I give it to you in different ways to make sure you understand. So they're going to block sodium and potassium so the client don't pick it back up, so it makes them hypo. Okay, but they reabsorb calcium, which I mentioned earlier, causing hypercalcemia. Your loops waste everything. Terrible. And your potassium sparing, your spironolactone, holds on to potassium. Great recap. Your adrenergic beta blockers, more recap. So, you know, there's alpha and there's beta. We pretty much talked a lot about your betas. Let me mention a couple of the alphas. Okay. Phentylamine, we talked about an endocrine, great for your pheochromocytoma client with the hypertensive crises. That's where we would use those, but you need to be familiar with them, that they're beta blockers, but alphas. Okay. Clonidine, we've talked about. So great for the antihypertensives, but your Raynaud's disease, that's where they come in. I just mentioned pheochromocytoma. We've talked about angina. All of them, orthostatic hypotension, right? Educate the person. Don't get up too quickly. And they, you know, if they're feeling like this, they shouldn't drive or go mow the lawn or anything like that. Now, there aren't many drugs that we tell you to give with milk, but here's an exception to that rule. So when things are odd like that, because we're always saying the opposite, right? Because but this is a special case. We want to administer the oral alphas, right, with milk to minimize that GI effect, which is a little opposite of what we tell you all the time. Your betas before meals in the morning, especially if it causes them to stay up at night. That way they're up during the day and then they can sleep in the night. All of them, you're never going to give these drugs without checking blood pressure and pulse. That's just not going to happen. Okay. So all of them. And if we're below 60 beats per minute, you're holding it and you're notifying the physician. Okay. Watch out for hypotension. That's what's at the other end of the spectrum that I keep talking about. Okay. And we're monitoring client because there may be a need to adjust these medications based on the side effect, the adverse effect, what's going on. Right. I have to mention the complementary alternative medicines, your herbs. So with the antihypertensives, a lot of these herbs don't mix with these drugs. Some of these herbs are going to enhance the effect of the drug and some are going to decrease. So we need to know all of the herbs that the client may be on. And this is education, because sometimes people just don't know, right? And especially with islanders, they just don't know about the mixture. So if the client is using garlic, right, to lower their blood pressure, or ginseng, hawthorn, snake root, be familiar with those because they're known to be used to treat hypertension. And here goes the client doing this to decrease hypertension and on a prescribed antihypertensive. So we must always do a medication reconciliation and ask about the herbs. And you know, they lack research, right? They lack research. They can't be prescribed. They're not approved by the FDA. Okay, but your supplements are, right? CoQ10, that is, right? So we can do the omega-3s. We can educate people, add more omega-3s in your diet. Those are the natural ways we want folks to do things, okay? So amino acid. Yep, those are researched and can be prescribed and recommended by your physician. Okay. There's a test question on licorice and ephedra. There's an adverse effect with those. If you use those with hypertensive client, they could go into a hypertensive crisis. Right? And sometimes folks don't know, they just boil this stuff and take it, and it was a problem. All right, we will cover a couple more topics before mental mini break. Now, we've been doing about 50 minutes, right? And taking a break, which is good. You want to build your stamina, right? Because when you go for the NCLEX, you're going to be sitting there for more than 50 minutes, right? So as a matter of fact, that's something I would love for you to practice. Practice sitting and taking 100-question test, okay? And towards the end, I want you to be doing at least 150. That's why you'll see at the end of the program, I have diagnostic tests that are 145, 150 questions, because remember, I'm training you for what you're going to see at the end. So it wouldn't make sense for you to stick to 50 questions, but no, because minimum you're going to get is 85. I wouldn't be helping you if I don't give you at least the 85, but I'm preparing you for both the minimum and the maximum. My prayer is for everyone to get the minimum 85, whether you're PN or RN. And CSPN says the minimum you're going to get is 85 questions, maximum 145. So minimum, you have to sit for 85. The majority of the tests that are built within my program are 100 questions, because I figure why not stay in the middle, right? But I want you to build your stamina. You need to be able to sit for 100-question test. Yes, go use the bathroom if you need to, but you can't start the test and go to work, right? Don't start the test if you don't have a good 2-3 hours, because I would love for you to remediate the test after you're done. Remember, you must do that. But we have to build stamina. So I need you to focus for me for at least 50 minutes. Then you can pause and go take a break. But until then, no. Tune in. So here's another nice topic. I always struggle where to put this, but I know it's on your NCLEX. So sometimes you get questions about how to save a body part, right? A body part that's been severed. How do you save it? Okay, there are traumatic amputations like this, whether it be a finger, a toe, whatever. How do you properly handle that for it to be re-anastomosed, right? Put back together. So there are cases where, yeah, the body part can be reattached, but how do we save it? Okay, it needs to be wrapped in a clean, damp, right? Moist, wet. Okay, placed in a sealed plastic, not paper, plastic. Okay, the paper bag question is with your metabolic alkalosis client, or your client who's been sexually assaulted, so we can save the DNA. Those are the paper bag questions. The plastic bag question is this one. So sealed plastic bag, immersed, dump it in ice or ice water. We need to keep it cold, okay? When it's cold, you keep it alive, right? And that way we can put it back together, okay? So silly little question that you don't want to miss. Yeah. Our next topic is shock. I do need you to be mentally together for this one, because there are different types of shock. You need to know the different types of shock and how to go about treating them. If you mix the type of shock, you could potentially harm someone. So I do need you to be mentally focused for this one. So let's go ahead and take a break, right? Pause, bathroom, snack, and come right back. Okay? All right, because this one I do need you mentally awake. All right, we will continue with shock. So as I mentioned earlier, shock is, those type of questions are higher level difficulty question. This isn't just you recalling, showing you understand. You have to be able to apply and connect information and properly treat clients with this condition. So nice high level questions come from this area. Okay, so what is shock? Let's start from the beginning, right? What is the definition of shock? What is happening pathophysiologically? How does the client look as they get worse and worse and worse? Okay, so the general definition is not enough oxygen, right? Inadequate perfusion and oxygenation of the cells, literally not enough. And we know when that happens, death of what? Tissue and organs, and eventually the individual as a whole. So there are 4 physiological components to regulating homeostasis, right? To having that balance that we keep talking about. I talked about homeostasis a lot. So if you have one or more of these components not functioning or malfunctioning, you're going to go into shock. So there are different types of shock, and you do need to know each type of shock, what's happening pathophysiologically, and the treatment will make sense. Okay. So there's at times where the client doesn't have enough output. So adequate cardiac output, we need homeostasis with that. We need the right amount. Okay, vascular system needs to be functioning properly, and it needs to not be compromised. So we need an uncompromised vascular system. Anytime there is compromisation, decreased blood flow, shock. There should be an 8 here. Adequate blood volume. Yeah, we don't have enough blood flowing, right? Whether it be blood or fluid, that's a problem. So sometimes it's the tissue that can't extract or use that oxygen that is flowing. Okay, ability of tissue to extract and use oxygen. If we can't pick up that oxygen, that too is a problem. And there's conditions where that is happening. So these fall under different categories. So when we're talking cardiogenic shock, that is the heart pumping system failing, the contraction, right? We talked about how we want a beautiful squeezing and 60% or more of the blood flowing through. There are cases where that's not happening. Obstructive, that's a mechanical, right? Obstruction, mechanical blocking. So mechanical interference with ventricular filling or ventricular emptying. So you know we talked about the ventricles receiving blood and squeezing and pushing that blood forward. So that is an obstructive or mechanical problem when the heart cannot do that. There's also distributive, which is usually a vagogenic issue, and this could have multiple causes. So we would look at the underlying cause for this one. Septic is an infection, right, in the blood. Anaphylaxis is allergy, right, an allergic reaction. And hypovolemic, hypo, not enough, volume. Okay, hypovolemic. So these are the different categories or types of shock. Okay, and you could come up with a little mnemonic to remind you or reinforce some of this. So there's cardiogenic, there's hypovolemic, there's anaphylactic, there's neurogenic, and there's septic. So some students remember CHENS. If that helps you, great. But you should be good with the types of shock. So just to recap, cardiogenic, ventricular loses pumping power. The heart cannot contract. Hypovolemic, not enough fluid, blood loss. Hypo, not enough. Fluid volume or volemic volume. Anaphylactic, allergic reaction. Neurogenic deals with the sympathetic nervous system. And septic, infection. Okay, so now that you know the different types of shock, okay, we need to talk about how do we treat the different types of shock, okay? But in general, you know, there's going to be a decreased cardiac output and perfusion. The body is going to compensate, and we'll talk about how the body does that. The body automatically does that, right? And there's the neural kicks in, hormonal kicks in, chemical kicks in. So let's talk about that before we go into treatment, okay? All right, so neural compensation. Remember when we covered I covered this in cardio earlier and in respiratory, where I show you how the heart is connected to the other systems, right? Your respiratory and your neural, there's a connection. And I tell you, don't ever think of the systems separate. They're not. Why? Because the body compensates. And you see that even with your, when we cover acid base, right? With the lungs and the kidneys, there's a lot of compensation happening here. And that's just how we're designed. Okay, so there are these baroreceptors in the carotid sinus, in the heart, in the aortic arch. Remember that? So whenever the heart senses that decrease in oxygen, okay, it's going to cause the heart to pump more blood, right? To get more blood to the system. But it doesn't matter if there's not enough oxygen. That's a problem, but that's still a compensatory mechanism. Your sympathetic nervous system kicks in. That causes that stimulation of the heart, right? You're going to be in tachy. So that tachy, okay, that's a compensation thing. But if it's a decreased oxygen, it doesn't matter how much blood is flowing. If there's no oxygen in the blood, that's a problem. So you know your sympathetic nervous system kicks in, but your parasympathetic kicks in as well, but it's gonna affect your feed and breathe, right? So that's why you see here there's a cut of blood flow to the kidneys and the GI. That's the whole feed and breathe. Remember, fight and flight, feed and breathe. So your fight and flight gets activated, hence the tachycardia, but you have decreased urine output, decreased motility in the GI tract. That's the neural compensating. Hormonal also kicks in. So you're going to get a decreased blood flow to the kidneys, releasing angiotensin, which we just talked about. You see how this is so all connected. So that's going to cause a constrict vessels, okay? And that's going to increase blood pressure. We just talked about your blood pressure going up due to an increase in angiotensin. And we talked about your antihypertensive that comes in and blocks that to lower your blood pressure. So here's another connection to that, okay? So that's going to cause constrict vessels and increase your blood pressure, because in shock, your blood pressure is going down, right? And your heart rate is going up, your respiration is going up. So here, the body's trying to fix that. Now, if it's minor, it can, but eventually we need external interventions, which we're going to talk about the external intervention, but we're going to talk about first how your body tries to fix this. Okay, so hormonally, you're going to be releasing, okay, angiotensin, which is going to help your blood pressure go up, because the problem is your blood pressure going down. Okay, so angiotensin is going to stimulate aldosterone. Aldosterone is going to make the kidneys retain sodium, which increases serum osmolality, right? Which in turn stimulates your antidiuretic hormone, which we've talked about before, which is going to cause you to not pee. Okay, and that increased sodium in water is going to cause your blood pressure to go up. That's what we want to do, because the problem is your blood pressure is going down. That decreased urine volume is going to increase urine specific gravity. So your hormonal part is the pituitary. This is covered beautifully in endocrine. So the anterior pituitary is stimulating and is going to secrete adrenocorticotropic hormone, your ACTH. So ACTH is now going to work on the adrenal glands that sits on top of the kidneys, specifically the cortex, the outer, with the whole epi and norepi. It's going to cause the secretion of glucocorticoids. And remember, that's epi and norepi, causing the blood pressure to go up. So that's how the body's trying to keep you alive. Okay? So chemically, so far we saw neural, we saw hormonal, so now chemical. Okay? So chemically, there's going to be a decreased pulmonary blood flow causing hypoxemia. Okay, not enough, so it's going to demand less, which is great. So that hypoxemia, though, is going to be that receptor, they sense that. It senses there's not enough. So when that happens, that chemoreceptor automatically, there's no button repress, everyone. Your body's automatically doing this. So you're going to, right? You need that oxygen. Okay. When your body sense that decreased O2, it's going to want, it's automatic. You're automatically going to do that. Nothing, we're built this way. Then that's going to cause a respiratory alkalosis. Isn't that, to me, that's phenomenal. Like when I think about it and process it, we're so uniquely designed, and it's great that there is a natural compensatory mechanism. So if we catch this at this level, we can do something about it and save the client's life. This is terrible when these things happen and nobody's around. Okay. So now let's talk about how these clients will present, right? What are the clinical findings? That's what you need to spend some time on because they're described, right? These clients are described to us. So clinical findings at this stage are vague because of the compensatory mechanism, right? The body's shutting down, but the defense mechanism is coming in to undo a lot of what we're seeing as the client's blood pressure go up. You see a lot of different system kicks in to bring that blood pressure back up. So they're going to be anxious, restless, tachy, right? Skin is going to be cool and clammy, thirsty, pupils dilated, the tachy again. The pulse is going to be weak, depending on the severity. It may be normal at first and gets weak. No bowel sounds or decreased bowel sound, decreased urine output. The urine is concentrated, and you saw the why based on what I've just gone over. Now, there's still time to intervene, but if we don't intervene, at the end of that is death. Okay, because the client would then go into a progressive stage of shock, progressive, where organ starts to die. That's a problem. So as the body compensates, if it's not able to do so, then organs are not getting oxygen. So there's a decreased perfusion to the organs. So they become severely hypoperfused. Cells are dying, organs are failing. They're in a severe lactic acidosis and metabolic acidosis. So at that point, they have a decreased level of consciousness, obviously, low level of consciousness. Respiratory wise, tachypnea with hypoventilation and lots of crackles and wheezing, adventitious breath sounds. So at that point, the systolic BP is below 90. They have a very narrow pulse pressure. They're tachy and irregular, weak pulse, volume less than 20 mLs per hour. You know we need between 30 and 60. Yeah, and death comes at the end of that if we don't intervene. Refractory stages, shock is irreversible death due to multiple organ functioning syndrome. Okay? So heart fails, respiratory, renal, liver, and then of course the client dies. Okay, so now that you know the different types of shocks, the patho, how the body compensates, we have to treat. So let's talk about treatment. So we're going to treat based on the type of shock, okay? So the very first one we want to cover is cardiogenic, okay? So with cardiogenic shock, that is where the heart is not contracting, right? The pumping. We need pharmacological treatment, right? We need those positive inotropic agents. Okay, that's going to cause an increased myocardial contractibility to get the heart to contract. So the butamine, we've talked about already. So you see, this is coming full circle. I love it. Full circle. Okay, it's like internally pumping the heart. We need those vasal dilators to improve the heart's pumping action. It's going to reduce the workload. This is not a heart we want working hard. Okay, this is not a heart we want working hard, but we need it contracting. So those vasopressors have to be part of that regimen as well. So those are going to increase peripheral vascular resistance to get that blood pressure to go up. So epi, dopamine. I have a little table for you. Let me show you the table and then I'll come back. This is a great table to be familiar with. Okay, dopamine, dobutamine, norepi, okay, isoproternol, phenylephrine. Yep, this is a great table. So you know the purpose of these, right? We need that blood pressure going up. We were using them for shock. That's what we're talking about, your cardiac arrest client. But you need to know the major side effects. And you can go to the other end of that spectrum to know those side effects. We're treating hypotension. An effect would be severe hypertension. That's just the way it is. Okay, so spend a moment here in this chart. It's going to take you a minute, but yeah, be familiar with it. Let me go back to the actual slide. So some of you, your brain works that way where you need to see the chart. My brain works that way. Of course, they're going to be on oxygen. There's a lot of supportive measures that we do. We may want to monitor the pressure in the heart internally. Okay, so that's all for cardiogenic. Now let's talk about hypovolemic, right? Not enough volume. You need to replace it. That's simple. So you're going to see the crystalloids, right? Hypertonic solution. You're going to see the colloids. We may need to give blood, whole blood. So depending on what's going on with the client. So that is the treatment for hypovolemic. Anaphylactic, there's a lot of vasoconstriction, right? With this one. So we need vasodilators. So that's your epinephrine, your antihistamine to decrease that against, because they're releasing, because it's an allergic reaction. We need the aminophylline, great bronchodilator. That's what's happening here. As I mentioned earlier, neurogenic could have a number of causes. So depending on the cause of that, we would look at the underlying cause. Septic shock, there's an infection. Fluid antibiotics. Fluid antibiotics. Okay, and if they continue into the shock, then we would go into the positive inotropics and the vasopressors that we talked about for cardiogenic shock. Okay, now you see why I wanted you to take a deep breath on this one. Okay. Let's talk about some adrenergic agents, okay? Because of what we just talked about, let me recap on this one. So we're talking about your epi, your norepi, your ephedrine, dopamine, you know, that whole table that we just talked about. Albuterol too, great vasodilators. So these drugs are going to stimulate both alpha and beta. We just talked about alpha and beta earlier, okay? They're triggering the release of a wonderful little neurotransmitter, catecholamines. So keep that in mind. Whenever we have medications releasing catecholamines, you are impacting the sympathetic nervous system. Okay? I mean, great for these conditions we're talking about, right? Great for the shock, the hypotension client we're talking about. Great for the anaphylactic shock client we're talking about. But you have to think of these adverse effects that are coming. Okay, so there's a spectrum. You want to think of things on a spectrum. Okay, so some adverse effects are going to be the restlessness, the insomnia. Don't forget the potential angina, tachycardia. So don't ever think, oh, okay, we treat it, we stay there. Monitor for that extreme on the other end. So as a matter of fact, these drugs, your adrenergics, okay, that are impacting your sympathetic nervous system are contraindicated with certain clients. Any client where the disease is causing hypertension, like pheochromocytoma, hyperthyroidism, your cardiovascular diseases, not a good candidate for these clients. and they do cause GI issues, which is minor, right? In the grand scheme of things of what we're talking about, that's a period, not a big deal. Okay. Couple more conditions, you're almost at the finish line. So hold on, let's talk about aneurysms. So when we're talking about aneurysm, there's a thinning, okay, or a stretching, dilation of the arteries. That section gets weak. It loses its elasticity, its thickness, and that's happening in the walls, like you can see in this picture here. And depending on where it's at, the terminology will change, whether it's in the chest, thoracic, or abdominal. But if it's an aneurysm, that's what's happening pathophysiologically. One of the most common cause of this is plaque fat arteriosclerosis, right, in the walls. So the only treatment for these is surgery. Okay, so if the client has an outpouching because of that weak wall, yeah, in some skinny clients, you can see it, very dangerous. Our job is to make sure this doesn't burst, right? No perforation, it doesn't, because then they'll bleed to death. Okay, and sometimes, for some clients, it's the entire wall, and sometimes it's a little section. But either way, it's dangerous and we don't want this bursting. So let's talk real quick about some of the diagnostic tests and treatment. Again, the term change depending on where it's at, okay? And often clients are not even symptomatic, so they could be asymptomatic. There could be like a vague chest discomfort or abdominal discomfort. They may be a little hypotensive, maybe some diminished pulses, but often they don't have signs and symptoms. So this could be diagnosed with an arteriography, and it has to be fixed surgically. There's no pill that's gonna fix that. They have to have surgery. So usually your questions come post. So prior to surgery, you don't want it to burst. I mentioned that, but there's a lot of questions post surgical procedure with these clients. So you want to always think post-op. Okay. And these are the clients we tell them, don't sit for a long time. Don't lift anything heavy. My goodness, right? Lots of teaching. Okay. Don't lift anything heavy because then you risk, even pre or post-op, you're not lifting anything heavy. Okay. But it has to be done surgically. Okay. Another type of condition we need to go over, these are minor, obviously. We've covered the major stuff, the MIs, the anginas. Yeah, we've covered the drugs. We just have a few left, nothing major. Your arterial occlusive disease are important as well. Okay, let's focus there for a moment. So there's not enough blood supply in the arteries. Usually those are in the lower extremities and the legs. They could be chronic, right, accumulated within a long period of time, and it could be acute. Okay. So, but either way, there's insufficient blood supply to the arteries. That's a problem. Okay. So they fall under the arterial-occlusive diseases, hence their names. So it could be an emboli. Okay. It could be plaque, fat, whatever it is, it's blocking the way. Okay. And commonplace is the femoral artery, very common. So these clients are going to have pain in that affected area. There's going to be some swelling. It could be blue, cyanosis, discoloration. And if untreated, that area dies, gangrene, necrosis. That's not good, right? And they may get that tingling, paralysis type of feeling, like that paresthesia to that extremity. Okay. So management. So we need anticoagulant. There'll be an IV heparin. It may need to be surgically removed, right? Ectomy, removal of. If it's severe, we're talking gangrene, necrosis, they may need an amputation. They need an angioplasty. So the earlier you catch this, the better. I don't know if you're familiar with the 6 Ps. If your teacher taught you this is a good way to remember these via what we call the 6 Ps. So there's that pallor, right? That modeling pill, the pain, the paresthesia. I just mentioned, after a cramp, they get that tingling sensation. They need to move the extremity. The coolness, okay, similar to the pallor, the mottling, because there's decreased blood flow. Whenever there's decreased blood flow, cold. When there's blood flow, you're warm, okay? pulselessness, literally, nothing. Weakness, muscle spasm, which is the paralysis that they get. And that's a nice picture of this right here. Enjoy my visuals. You could see there's going to be decreased blood flow on the other end of that. And what's on the other end of that is going to die. Okay. So right here is a beautiful, healthy, blood flowing, okay, normal open valves. You know, there's no blockage of traffic. Beautiful. It's not beautiful over here. Okay. And this could even cause reverse flow. And you see there's stages of these. Start with the tiny little spider veins, and then this is just 5. Yeah, this person is going to have some signs and symptoms, decreased sensation, that tingling. Okay. So now, test questions. We got to get here. Sorry. Difference between arterial and venous insufficiency. And you have to spend a moment here. I'm going to pull out test questions, what's important, but you have to go in the comfort of your closed environment, the library, your closet, wherever you go hide to study, to process this, right? Arterial and venous are not the same. And if you're mixing them, you're going to get these questions wrong. So let's do arterial first, and then we'll go to venous, okay? So arterial, pale color with elevation. Literally, what physicians will do, or nurse practitioners that even go to the home, because I used to follow a wound care specialist in the home. I loved it. I learned so much from this lady. Awesome lady. She built the care center at Aventura. Such a wealth of knowledge. She would just go to the homes and put a pillow underneath the client's legs, to diagnose and differentiate this. So pale color with elevation. Put a pillow underneath their feet, couple pillows, elevate that, or just lift their legs up. Okay. They get that dusky red color when lowered. So that's a big difference. Okay. So dusky red when lowered. Okay, reddish brown cyanosis for venous when lowered. So I think this is one of those areas where at least focus on one and one, the other, because we're going to be seeing a lot of opposites here. Okay. So for arterial, skin is thin and shiny. Okay, remember these. Pale color with elevation with arterial, dusky red when lowered. Their skin looks like you stretched it. They don't have hair. Okay. Thick nails. They have these painful ulcers that don't bleed. Okay. They're black and they take forever to heal. Like forever. They act like a diabetic. These clients are cool to touch. The pulses are diminished or absent at times. And you see here opposite. It's strong and regular and venous. So in arterial pain, achiness, fatigue, burning, discomfort, it's not a good feeling. And they have it all the time in their calves and thighs. And when they go to walk, okay, activity, and when the limb is elevated, it's painful for them. Nasty. They get these little ping ping, like that's how they describe it, like a pin sensation. Like if you've ever had cramps, similar to that. And it's so bad where stuff can't touch them, like a light cover can't touch their skin, that it's so. They don't usually have edema. If they do, slight edema. Whereas venous, lots of edema. So that's arterial. Okay. Now venous, yeah, there's a lot of opposites here. Okay, I've covered a few of them already. So you have to kind of, not mix them. So with venous, the pain is a big deal. Pain that gets worse when they're standing. Pain gets better when you put a pillow underneath their feet. Arterial, pain is exacerbated when the limb is elevated. Pain for venous, pain gets better when the leg is elevated. So they're opposite. Work on one and you know the other. Arterial edema, venous no edema. Okay, so don't get this question wrong. All right, two more. Raynaud's phenomena. Now, students have told me on the NCLEX, they get the arterioplastic disease term. Know both, right? Know both. Know that Raynaud's disease is also called arterioplastic disease. It's an arterial little problem. So, pathophysiologically, what is happening? Vasospasm of the small and medium blood vessels. So blood is going in and out. That's a little something we call intermittent claudication. Okay? Episodes or episodic vasospasm of small cutaneous arteries that result in intermittent paleness, blueness, right? Pallor and cyanosis of the skin. They're usually in the extremities, fingers and toes, but it could be their nose, their ears. So there's a whole in and out. Okay, with the flowing of blood. So their fingers look like that, red, red, and blue kind of madness going on. Now, the cause of this is extreme temperatures. More in women than men for women, right? So triggers like stress and cold, extreme temperatures. So if we know the cause, we can, get the client out of that condition. Treatment. Your calcium channel blockers. Yay! Which you're very familiar with already. Nifedipine, daltiazem. Your alphas are great for those because they're going to get to that small blood vessels and open it. They're going to dilate. So these clients need these vasodilators for these type of problem. And if it's bad to where there's gangrene, it's an amputation. That's the answer for that. Once we're hitting gangrene, dead, it's an amputation. Okay. So, and clients that smoke or excessive caffeine or extreme temperatures, that's all teaching, right? We're going to teach them. No more of that. Okay. Here's another one that's on NCLEX, similar, but causes are different. Thromboangitis, also known as Berger's disease. Okay. Now, this is the medium and small arteries again, that intermittent claudication again, same patho of what's happening. Okay, this one is more in men than women, definitely in smokers. Okay, this disease only occur in smokers. Here's an absolute, only occur in smokers, but same patho, right? Same patho with Raynaud's. Okay, it's those intermittent claudication. So arterioplastic disease and thromboangitis are similar in that way, but the causes are different. You're only going to end up with thromboangitis or Berger's disease if you're a smoker. Okay, so one thing would be not to smoke, right? That would be a preventative measure for that. But same treatment. If there's gangrene, there's going to need to be an amputation. They should stop smoking. Idea to prevent this. Okay. So these are the drugs we're going to use for alphas. Again, are great for those. See, Raynaud's disease, hypertension, pheochromocytoma. You see how these drugs have multiple purposes. Okay, hence why this is the same exact slide as before, because that would be the same exact treatment, that family of drugs. Thrombophlebitis. I just saw a very nice next generation case study. So I'm revamping this case study. It's an evolving one. So it's an evolving case study with thrombophlebitis. And I found it very interesting. And I see exactly what's happening with next gen and the why they question you that way. And this is a nice case study. So you're going to see that I have to tailor it and make it my own, but I love it. So it's a case study on thrombophlebitis. So there's a clot, thrombo, hence the root word thrombus. There's a clot. Okay. in the blood vessel. Nasty condition. So there's going to be that inflammation in the wall and it's going to block the way. That's a problem. Lots of causes for these IV drug users, prolonged immobility. That's why whenever we admit a client to the hospital who's not mobile, right, we need to make sure we're thinning that blood. Okay, we need to make sure we have the TED hole, the compression stocking, something, because we need that blood moving and circulating. So whenever you have immobility, right, of course, they're caused from the catheter, trauma, a number of reasons. And with thrombophlebitis, know the findings, right? There's going to be redness, swelling, tenderness. So let's look at the history of this client, what's going on, what could be causing it. Now, as it is in the lower extremities, priority, 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 bed rest. Why? Because if the client gets up and now walks, you move it. And where is it going to go? The lungs. It's going to travel and block the way. There's not going to be any oxygen. So that's now pulmonary embolism. We don't want that. So management, bed rest. We could prevent this with the STD boots, the elastic stockings, Lovenox, right? They're painful. So if we do see that, we want to monitor for pulmonary embolism, because if it travels, that's exactly what's going to happen. So let's go over signs and symptoms of how that client would present. So if we weren't able to prevent this and we are in the pulmonary embolism state, that this deep vein thrombus has traveled, or this thrombus, we're going to talk DVT in a moment, it's going to lead right into DVT. It's just a topic. So sudden pain, cyanosis, hemoptysis, that's late stage, folks. Hemoptysis, right? Blood, shock, changes in the vital signs. They've gotten worse. So we can teach the client some measures to take to prevent this from happening, and if we can put it in the hospital. But eventually we may be talking about a deep vein thrombus here. Okay, so that's a beautiful picture of that. You can see why now the client should be on bed rest. We don't want this dislodging and moving and blocking the pathways. Number of causes, again, a number of causes for these. So we can prevent it with some of it we cannot prevent, so we would monitor. So bed rest, bed rest, bed rest. Pharmacologically, anticoagulants, thrombolytics. We can bust the clot that's currently there with the thrombolytics and prevent future clots with the anticoagulants. And they may need surgery. We may need to have a thrombectomy, remove it surgically. So we're going to monitor the client for the pulmonary embolism in case this dislodges and travels. No more walking. So depending on what they're on, we will be doing the APTT, PTINR, if they're on warfarin. So this would depend on what they end up on. And then if they are on some type of thrombolytic or anticoagulant, we're monitoring for bleeding. Okay. But yeah, we can prevent this by not having the client stay on their backs for too long. Okay. All right. We are going to go right into practicing a few questions so I can make sure that you're processing this. So together with me, and we'll do this slowly, we'll go over the rationale because we're learning, we're in learning mode, okay? So we do these questions together, but you can throw me some answers, right in your chat, in your classroom. This is very interactive, okay? So the nurse has finished reviewing the shift report on a cardiac unit. The nurse should plan to see which of the following assigned clients first. A client with hypertrophic cardiomyopathy who is reporting dyspnea. A client who had a cardiac catheterization who will be ambulating for the first time. A client receiving antibiotic for bacterial endocarditis who is reporting anxiety and chest pain. A client who is recovering from coronary artery bypass, cabbage, surgery with a temperature of 101. Great question. I believe I put that in one of the other areas and went over the rationale. So if it's repetition, that's actually good. So usually I'll have students between one and 3 because of the dyspnea. But here's what's wrong with number 1. Dyspnea is expected with cardiomyopathy. So if it's expected, I'm not concerned. That. So cardiac cath, ambulating for the first time, this would be a circulatory problem. Okay, so we have an airway problem. That's before that, so get rid of that. So your antibiotic for bacterial endocarditis, reporting anxiety and chest pain, that is a pulmonary embolism client. So remember, this condition causes these large clots. And if the client is having anxiety and chest pain, it's because they've traveled and now causing a pulmonary embolism. That's your priority client. I'm not concerned about the low-grade temperature with the cabbage client. Nice question. But you see, first of all, this is a priority question because I see the word first. So that tells me about the nursing process, right? But all of these are the same. So it's not going to help me eliminate answers. So I really do need to know my condition, my disorders here, but I'm also using Maslow's hierarchy. Okay, the temperature is not airway, breathing, or circulation. The cardiac cath is circulation, so you should be between 1 and 3. And between 1 and 3, 3 is your priority. That is your pulmonary embolism client. Okay. This one is in learning mode, which means your answer is right there. That's because it's super easy. The nurse is caring for a client diagnosed with congestive heart failure, taking digoxin and furosemide, right? Because you know with digoxin, you cannot be hypokalemic, and furosemide is going to waste your potassium. So the electrolyte that I am most concerned about is potassium. Okay. So furosemide increases potassium loss, and low potassium could potentiate digoxin, causing the client to be toxic. Okay, so this would not be a high level difficulty question. That's why I have it in learning mode. Okay, I'm going to, let me see, because of the recording, let me see if I can mute your, I'll put it back on. All right, so great question. Okay, great question. Let's try this one. A client in shock has a blood pressure that continues to drop despite IV fluid. Intravenous dopamine is ordered at 8 microgram per kilogram per minute. The anxious client asks the nurse how the medication will help him get better. Which is the best response by the nurse? So, test taking strategies. Remember, you want to answer in layman's term, number 1. And what this question is doing, number 2, is testing to see that you know the mechanism of how dopamine works. Okay? We just talked about dopamine. Talked about dopamine being in alpha and beta adrenergic receptors. Remember that slide? So it's going to vasoconstrict, but you don't want to use the word vasoconstrict with a client. Unless they're in the field, they don't know what that is. So choose words that are like you're talking to somebody who doesn't know the language, because they don't. So is it one, dopamine will interfere with poor electrical conduction in the heart? And you see how you need to know how other drugs work too, because that's what they're doing here. They're giving you the ways of how other drugs work, but you need to know how your beta adrenergics, your alpha and beta adrenergic works. Is it two? It will cause blood vessel walls to tighten, which is another layman's term for vasoconstrict, to help increase the overall blood pressure. Is it three? It will make your heart contract less forcibly or forcefully, and thus decreasing the amount of work it has to do. Or is it four? It will increase your urine output through its effect on the kidneys. This is a nice question, folks. And this is why I teach the way I teach. Because if I don't teach you the mechanism of how the drug works, you're not going to be able to answer this question. And you can also see how you need to go back and redo this, listen to this again, take notes, process this, right? In order for you to be able to say, oh, it's a alpha beta, okay? They work via vasoconstriction, right? So what we've just done earlier prepares you for this. So hopefully you went with number two. So dopamine acts on the alpha beta adrenergic receptors, causing vasoconstriction, but you're not going to use the word vasoconstriction. Instead, to the client, you're going to say tightening of the walls, because they'll understand that. Okay, increase systemic BP and increase force and rate of myocardial contraction. One is not true. Three is the opposite. Four would be for what? Diuretic? Yeah. Question. So this shows you how another way these will come at you. So a lot of it I do verbally too because of time, but this will show you one way it comes at you. Here's another. The client was admitted with right-sided congestive heart failure and treated with diuretics. Great. And his edema cleared quickly on the second day. He was given a round of steroids because he has no appetite and was extremely fatigued. Okay. On day 3, he is feeling better at 8 a.m. when the nurse makes rounds. Around 10 a.m., the nurse's aide reports the client is having trouble breathing and his respirations are 42 and labored. The nurse finds that he has marked rales and rhonchi and an S3 heart sound and frothy pink sputum. The nurse suspects, awesome question, is the client returning to right-sided heart failure they were admitted with? Are they now developing mild left-sided heart failure? Do have some signs and symptoms here. Are they experiencing tamponade, which we've already covered? Or are they having a pulmonary edema? Now you need to do a process of elimination. If you can't see it right off what's happening, process of elimination. So first, they're not returning to right-sided heart failure because these current symptoms at 10 a.m. are not right-sided heart failure symptoms. So get rid of one. Okay. Now, number 2 says mild. These are not signs of mild. You having frothy pink sputum, that's not mild. Get rid of number 2. We talked about tamponade. Those are not signs and symptoms of tamponade. So even if you couldn't come up with pulmonary edema at first via process of elimination, you should have gotten there. And that's why I tell you, on the real exam, you're not going to see the exact same questions we're practicing here. You might, and if you do, don't tell anyone. But you have enough knowledge, enough test taking strategies to get to the correct answer. So the marked rales, rhonchi, the extra heart sounds, the frothy sputums are classic signs of pulmonary edema. it's the steroids causing this. Okay, side effects of the corticosteroids. Nice. These are level 3s and 4s. Okay, so they're not 1 and 2s. Obviously, we up the notch a little bit. All right, next. The nurse is explaining the pathophysiology of cor pulmonale to a client with chronic obstructive pulmonary disease, COPD. The nurse would explain that the pathophysiology behind this complication is the effect of the lung disease that will. This is a great question to see that you can connect the systems. And I keep telling you, don't ever think of them by themselves. They're connected. So here we are talking about cardiac and respiratory. That's really what's happening here. So the patho behind the complication is the effect of the lung disease that will, is it increased workload of the left ventricle? Now picture the left ventricle. Or increase the workload of the right ventricle? That's why I use pictures when I teach. I hope you rule out dilating the pulmonary artery or constricting the pulmonary artery. Okay, hopefully you made up your mind. Number 2. Okay, so let's talk about it. So chronic lung diseases cause hypertrophy of the right ventricle. So picture it, everyone. Okay, so the COPD, that's the chronic lung disease. So eventually the right ventricles are going to fail. That pressure, okay, because remember, that is the chamber that is pushing the blood to the lungs. Okay, if you imagine the anatomy. So the right ventricles are going to fail because of the increased pressure within the pulmonary artery that results from the lung disease, from the COPD. So right-sided heart failure is going to happen, even though it's from a respiratory problem. Great question to show the connection. And you have to really know patho to get this question correct. An RN is about to make first rounds after receiving an intershift report at 3 p.m. In what order should the RN see the following clients? Click and drag the option below to move them up and down. So this would change slightly for a PN, but you still need to know how to prioritize. So great question. So, in nursing, we don't just do things, we do it in a nice orderly fashion. So we need to know that you can put your clients in the right order of how you see them. So you just got report on all these folks. So one of them you need to see first, second, third, fourth, fifth, like that. So this would be a drag and, put in the right order. So you would move this. But for the purpose of us doing it together, we're going to take a look. All right, so 1, a 54-year-old client 4 hours post-cardiac catheterization who has mild discomfort at the access site. Okay, as I'm reading this, I'm thinking, nothing priority here. That's not going to be my first patient to see. Let's look at the others. A client newly diagnosed with diabetes mellitus who needs reinforcement of sick day management guide. Okay, sounds like a lot of teaching. Nothing acute here. Next, a client who arrived 30 minutes ago from the post-anesthesia care unit. Okay, your keyword here, arrived 30 minutes ago. So they haven't been assessed. So I need to make sure they're alive. Let's hold on to that one, right? 4, a client who is ready for discharge, but will not have transportation to home available until 5 p.m. Okay, nothing wrong with this client. They're ready for discharge. Yep, nothing acute. I don't need to intervene. So to the back. Let's look at the next one. A client with pneumonia who has received 2 doses of IV antibiotics and has an O2 sat of 93. Sounds like my next client to see, right? So my newly arrived client or 30 minutes arrived client has to be my first client. And then the antibiotics with the O2 stat of 93. That's got to be the second one. So let's relook at the others, which is what, 1, 2, and 4. So 1 was the post cardiac cath. 2 was the teaching, the diabetic teaching, and 4 was the discharge. Okay, so out of these 3, my cardiac cath has to be the next one. Yeah, the teaching can wait and the discharge can wait. So then I have 3 as my first client. I need to see they just came back to the unit after a procedure. I need to see them. They haven't been assessed. They could be dead. 4 is my IV antibiotic with a 93 stat. That's my second client I would see. I'm sorry, which is number 5. And the next one would be number 1, my post-cardiac cath client. Okay, so I'm between the diabetic that needs teaching, right? Needs reinforcement, sick day, management guidelines, yep, and my discharge. So here's what you need to keep in mind. Between those 2 clients, the person that's going to take you the most time, you need to leave last. And that's going to be your teaching client. Newly diagnosed, they don't know how to self-inject, they don't know how to manage their intake of excess carbs. Yeah, lots of teaching. So number 2 would be last. So the 4th person I would see would be my discharge client, and then my newly diabetic, because they're going to take me a long time to educate them, for them to demonstrate all of that. So let's recap. Nice question. Okay. So priority setting can be implemented in a variety of ways. So the best thing you can do with these questions is practice, and I have a ton of them for you. So the post-op client needs to be seen first because they're newly to the unit. You haven't assessed them. We want to make sure, they're not coding on you. The pneumonia one would be next because of the airway. That we're not too worried about, but still, that's your next client because the others don't take priority over that client. The post-cardiac cath client would be next. You need to evaluate that, assess them, the extremity. And then your discharge client would be after that. And then your teaching client is last. So determine the client that is at greatest risk and then followed by the others. The client with cardiac cath could become unstable, so that would be your next one. So this client can be 3rd. The discharge, now the diabetic teaching, because of the time frame. The client needing teaching will need time and leave them last. Because imagine you spend all that time teaching them, the other clients are coding on you. Or getting worse. Nice question. It was packed with a lot. All right, here's a different one, a pretty simple one. A client is being maintained on heparin therapy or DVT, deep vein thrombosis, which we just covered. The nurse must closely monitor which of the following lab results. Very easy. Heparin. Okay, so we've talked about that. That's going to be your APTT. If you didn't know that, yeah, you should know that. Then you weren't listening to me. So heparin is used to prevent the further clotting from being formed and prevent the presence of clots from margin, which is great. So it's the APTT we use for that. It's very simple, straight to the point type of question. If I change that to Coumadin, then it's going to be the INR. Okay, the PT INR. It's just that simple. So here's another nice one. You are caring for a client with deep vein thrombus who is on heparin IV. Your latest APTT is 45 seconds. If the laboratory normal range is 16 to 24, you would anticipate. So remember, you memorize that whole 1.5 to 2 times, the little table that I showed you when I covered this. Okay, remember the whole therapeutic range for APTT is 1.5 to 2 times the control. Okay, so the lab normal they're giving you here, the laboratory normal range is 16 to 24 seconds for this client. Okay, so would you maintain the current heparin dose? Is that a therapeutic? If you memorize your little values, yeah. Is that therapeutic? Number 2, increase the heparin as it does not appear therapeutic. So they're just testing to see if you memorize that. Would you give the antidote? Would you repeat the blood work 1 hour later? That is within range, everyone. So you guys are going to maintain. Okay. So your 16 to 14, I'm sorry, 16 to 24 seconds is within the therapeutic range. So just monitor. The nurse is administering lidocaine, xylocaine, which we've talked about, to a client with MI. Which of the following assessment findings requires the nurse immediate action? I hope this pops up and hits you in the face. Okay, so that, yeah. And on the real NCLEX, it's extremely abnormal like that as well, folks. So hopefully you're going with that ridiculous pulse of 48. Okay, so lidocaine is going to cause Brady, so we're monitoring for that, and you're going to need to intervene for that 48 p.m. question. So I mentioned this before, they're always on monitor. Always, you're not going to be giving lidocaine without putting the client on an EKG monitor. Hang in there, a couple more. A nurse admits a client transferred from the ER, from the emergency room. The client diagnosed with an MI, myocardial infarction, and they're complaining of substernal chest pain. They're diaphoretic and they're nauseous. The first action by the nurse should be to, we're going to talk about this question and flip it around a little bit after you come up with your answer. ER, MI, chest pain, sweating, nauseous. Are you going to order an EKG, administer morphine, start an IV, or measure the vital signs? Send me some answers. Yeah, make up your mind. So it's the morphine. Let's talk about why. Okay, so I know you remember Mona, right? And we've talked about Mona, where now research shows it's best to put oxygen on the client first. So I could flip this question and put O2. If I do that, then the answer would be oxygen. Okay, then we want to do the morphine. But if that's not enough, because this is from what students are telling me, this question is coming at them at so many different angles, but you have to pay attention to the question, right? And your answers. Because if I switch the answers here, right, and I put oxygen, yeah, first thing you want to do, put that oxygen on them. Then do the morphine. Okay, then the nitroglycerin, then the aspirin, right? So administer morphine sulfate. So let's, yeah, decrease that pain. That'll be priority at this point. And so what the morphine does also decreases the oxygen demand. But if you put oxygen on them first, that helps more oxygen get into the client's cells, which is great. So the less oxygen the heart needs, the less harder it will need to work. Okay. Nice question, but pay attention how it comes because it could be flipped on you. Okay. Here's another frequent common one. The nurse is caring for a client with a serum potassium of 3.5. The client is placed on a cardiac monitor and they're receiving 40 milliequivalent of potassium chloride, 40 ml MEQs, and 1,000 ml of 5% dextrose in water, okay, intravenously, IV. Which of the following EKG pattern indicates to the nurse that the infusion would need to be discontinued? Okay. I hope you noticed that 40 milliequivalent of potassium chloride. So they're at risk of what? Hyperkalemia. Okay. Even though the potassium is fine here, 3.5, but they're getting 40 MEQs. So if they're hyperkalemic, how do we see that in the EKG? Yep, that tall peak T wave. Mm-hmm. Hyperkalemia. So we need to stop that. Okay. Next, the home health nurse would be most concerned for a client who is developing digoxin toxicity after noting which of the following during a routine visit. Hmm. They're just testing to see that you know when a client is toxic on the dig, which we went over. Yep, the anorexia, nausea, yellow vision, they're toxic on the dig. They may have some other visual disturbances. That's a level 2. Okay. Which of the following statements made by the nurse is most appropriate when providing client education regarding the use of hawthorn? So we talked about the herbs earlier. So here's a typical way the herb question may come at you. Okay? So which of the following statement made by the nurse is most appropriate when providing education regarding use of hawthorn? 1, you may use hawthorn for acute episodes of chest pain and angina. We're never doing that. Throw that out. Okay? Hawthorn will not affect your heart rate. Yes, it will. You should not take hawthorn while taking captopril. Good advice. I covered that earlier and showed you even the point and everything. Okay? Hawthorn is known to produce the same effects as verapamil, Callan. So yeah, you need to know about your herbs. So hawthorn should be avoided, okay, with contaminant used to use of prescriptions for antihypertensive, the whole family. You're not mixing this herb with your antihypertensive, especially captopril, okay, which is an ACE inhibitor. The pril, we went over them. So they have similar actions. You're double dosing. That's a problem. They're both going to be converting angiotensin 1 to angiotensin 2. That's too much. Yeah. So you're going to go over the rationale because you can learn, for a potential question that may come at you a different way. Okay. The client presents to the emergency department with substernal chest pain and is diagnosed with subendocardial infarction. The client asks the nurse, what does that mean? The nurse should tell the client that the damage is 1, on the interior wall of the left ventricle, on the posterior wall of the left ventricle, involving the full thickness of the wall, involving the inner layer of the heart. There's one keyword that gives this all away. And if you went through the anatomy and physiology that I did at the very beginning, this is very simple. Sub-endo. Where am I if I'm in the sub-endo? I'm in the inner layer of the heart. It's just that simple. Yep. Endo, remember endocarditis? So subendocardial infarction. Here's an example of a hot spot, and I'll just show it to you. So here, the nurse is teaching a class at an outpatient cardiac clinic held for parents of children with congenital cardiac defects. Before explaining the movement of blood through the septal defects, the nurse tells the parents about pressure gradients in the normal heart. The nurse will indicate on the picture of the heart that the pressure is greatest in which chamber. Where is the pressure greatest in the heart? We talked about this. There's one side of the heart that works hardest, the hardest or harder than the others. Which one is it? Left ventricle. You can see my cursor. Let me move this so you can see my cursor. Right here. There is an invisible box right there. Your left ventricle works the hardest. Pressure is greatest in the left ventricle because the heart chamber must supply blood throughout the body. That's a harder job, responsibility than to just pump blood to the lungs. That's a shorter distance. Okay? So pressure gradient is higher in the ventricles than in the atria. Left ventricle has the greatest muscle mass because it has to push blood to the entire body. Poor thing. The nurse is preparing to utilize an external pacemaker for a client with dysrhythmia. The nurse knows that this pacemaker often is necessary when a client is in which of the following cardiac rhythm. We're going back to cardio part 1. So would we need a pacemaker for ventricular fibrillation, atrial fibrillation, ventricular tachycardia, or a second-degree heart block? Go back to my wonderful madness. So we need a pacemaker for the blocks, okay? Your second-degree heart block. So client is in ventricular fibrillation, requires immediate defibrillation. We talked about that. A client with atrial fibrillation might require synchronized cardioversion. A client with VTAC, defibrillation, but a second-degree heart block, pacemaker. Okay. VFib, VTAC, defibrillate. Okay. AFib, cardioversion. Nice. All right. A client on a telemetry unit exhibits regular ECG complexes of normal duration and a heart rate of 82. Beautiful. The nurse assesses the client and notes that each complex, there is a corresponding palpable pulse. The nurse knows that for each pulse to be palpable, what had to occur? Ventricular contraction, ventricular relaxation, fibrillation, or cardiac standstill, which is asystole. What's happening when the client is pulsating? Each pulse. Every time you have a pulsation, a palpable pulsation, that is due to ventricular contractions, not relaxation, contraction. Depolarization of the myocardial results in contraction, systole, and that produces the palpable pulse, okay, and your QRS on your electrocardiogram. When the heart is fibbing, there's no pulse because it's fibbing. Okay. Great question. Okay, another hot spot. The nurse explains to parents of an infant with an atrial septal defect. Again, we're going back, right, to cardio part 2. Atrial septal defect. In a healthy heart, the blood pathway is right atrium to right ventricle to left atrium to left ventricle. You're good with that. We covered that beautifully. And explaining the altered cardiac blood flow in atrial septal defect, the nurse points to what area on the picture shown to indicate the first chamber receiving blood via the abnormal pathway. That's just a fancy way of saying what's happening with atrial septal defect. Where is this hole? There's a hole. Where's the hole? Okay. And this is a better picture to show you the hole. Okay. Atrial, between the atriums, septal, there's a hole. So any child with an atrial septal defect, blood flows the normal pathway from right atrium to right ventricle okay, to left atrium, to left ventricle. So there's an invisible box right there where the hole is. Okay, so some blood is gonna flow to the atrioseptal defect and back to the right atrium, right here. Okay. So this could be asked of ventricular as well. So then the hole would be right here. You could get questions on tetralogy that's similar to that. It's just a hot spot. All right, we have a SATA. We're very excited about that. Okay, select all that apply. Don't forget, towards the end of the review, there are hundreds of select all that applies for you to practice. I have them throughout the exams and throughout the PowerPoints and course for us to practice. But before you sit for the NCLEX, I would love for you to do all of them and remediate them. Okay, but I put them at the end for a reason. Your next gens at the end for a reason, because I need you to have content. You have to have a lot of content before you approach those questions. I think that is the best way to put a review together, because if you go do select all that applies and you don't have content, what do you think is going to happen? You need content, you need strong base, because that is what these questions are doing. They're testing to see how well you know content. So know content before you approach them. Now, remember, we covered your acyanotic and cyanotic pediatric cardiac anomalies. We covered those. So in assessing children with congenital heart defects, the pediatric acute care nurse would expect to see clubbing of the fingers and toes in a child diagnosed with. So you're going to see clubbing of the fingers and toes in conditions where there decrease of oxygenated blood, right? So those would be your cyanotic defects. So that is all this question is asking. They're testing to see that you know the conditions that are considered to be cyanotic defects. We talked about transposition of the great vessel. We talked about atrioceptal defect. We talked about tetralogy of Fallot. We talked about patent ductus arteriosus. You know the pathway with those. You know which ones are cyanotic and acyanotic. So there are two here that are cyanotic defects. Which ones are they? That's all this question is looking to see that you know. But they don't come out and say that. I could rephrase this question and say which conditions here are cyanotic, which conditions here are acyanotic. But no, you're at a higher level. So based on my description of the clubbing of the fingers, you should know that this is a cyanotic defect. Which ones here are cyanotic defects? It's the transposition of the great vessel and tetra. Those two are, okay, cyanotic defects. Great, great question. That's the only ones you're gonna see clubbing of the fingers in the cyanosis. I could flip this and make it acyanotic, okay? All right, everyone. So that concludes cardio. Wow, that was like days of in order to cover cardio. So this was pretty much probably like either your message 1 or message 2 when you were in nursing school, because cardio takes a nice chunk of those classes. As you can see, that was a lot. So I do want you to go back, you know, over all of this, take notes, take it slowly, practice these tests, but don't do the exams at the end of physiological adaptation until you've covered all of these systems. So let's go ahead and take a short breather. Okay, water, bathroom break, and then we will resume. All right, so that was the end of cardio. So I want you to go through the rest of the systems. You still have respiratory, neuro, endocrine, GI, GU. And then once you've gone through all of the systems, then you would take the exams, right? And don't forget to remediate those exams. It's extremely important, okay? Then you can do the SATAs and the next gen questions. All right, so happy study with that part.